My name's Susan Ramonat. I stood here on the stage a year ago representing a financial services firm as a chief risk officer, but someone who had been investigating blockchain for the better part of 2 years and had tremendous enthusiasm for what I had seen, certainly for the impact of financial services. Over the course of that last year, actually, I've been in transition in seeing how we might take blockchain into healthcare, and importantly hit some of the themes that David has reflected on, and certainly Angela and Bill and others, and focus on a use case that we think is relevant and pertinent. I'll share more about that, but I really wanted to be able to share a view around blockchain in healthcare, opportunities and challenges, and acutely recognize that actually some of the challenges I'm going to be raising are just those that financial services has, that you'll experience in other industries as you bring it in, fundamental questions, but also open up that lens and talk specifically about healthcare and areas of importance. I did take away, and I think we all should have now, a new hashtag hard to change. So with your ScotChain17, if you could hashtag hard to change, I think Angela's given us something that has some life and work on Twitter. As I thought about opportunities and challenges, really there are 4 elements to this. They're a bit interwoven, but I will start with use cases and encourage you as you look and think about applications, whether it's in an industry sector, cross sectors, and across the nonprofit area as well as agencies, to think of these areas in terms of the use case being primary. What problem are you trying to solve? And to David's point, in what sense is blockchain actually enabling or helping with this? And are we really just talking about blockchain, or are we talking about blockchain and some other technologies? I think another significant message today is there is a tendency to conflate what really is a record or registry that's auditable and upon which one can rely, and perhaps in a much higher level of assurance in terms of compliance, whatever compliance is defined as, and a conflation of that with other enabling technologies, which are very significant and very important, but not the same thing and not what blockchain is delivering. So I'll come to that as well. Use cases. In almost every use case in healthcare, and certainly as in the United States, the FDA solicited against a challenge white papers around the use of blockchain a year ago. Of the 75 or 78 white papers submitted, well over 2/3 talked about patients gaining control of their medical records and patient data sharing. And in fact, when you look at many of the use cases around blockchain, much of it is around patient data sharing being a requisite to enable other aspects of how it might be utilized. So I don't want to minimize the importance, and hence why I put it in the middle there, but I'm going to leave that as an open question for a few moments. I'm not taking that for granted. I will offer as well that when you look at those papers that I was referring to, some folks did, in fact, reference that the entire medical record would be on blockchain. That's a leap. But let's look over there on the right-hand side. The reason I've represented those in blue is those really are administrative processes and the like. They may or may not touch blockchain, but certainly supply chain. Some of you may have already seen reference to work in the pharma sector, requirements they have around serialization and understanding their supply chain from ingredients right through to delivery, through pharmacies and the like. Certainly applications there. Some of what we're doing might be described as supply chain, but there's a bit more to it. I don't want to belabor that right now. Claims and claims processing, pretty much a big deal if you're not in a single payer, single provider environment. In the United States, claims processing is a very big deal. Fraud and abuse associated with that. Relatedly, I have fraud and abuse over on that side, because whether there is supply chain fraud and abuse or around a claim issues, wherever that may occur within the treatment of a patient. Likewise, licenses and certifications. This is cross-sector. Licenses and certifications as a concept, whether they're associated with educational degrees and or other attainments, professional bodies and the like. These are all use cases that are being examined in healthcare, and they make sense. The Internet of Medical Things. We are working on medical devices across their life cycle, chain of custody, making and ensuring that those devices are in good order, whatever good order might mean, and to the extent that there are recalls or field notices or otherwise, that actions that need to be taken around a device are taken, whether that's within hospital, in a remote patient care setting, or upstream as it's come from a distributor and been imported and now sitting ready to be supplied to a hospital or to an operating theater. But in blockchain, some of the hype that is analogous to some of the hype around SWIFT and the elimination of SWIFT, there are folks that are working on the idea that a device-to-device world, machine-to-machine, completely enabled, regulating the Internet of Medical Things. So here I'll bring it and ground it very specifically. For diabetes management, in fact, for many of the chronic non-communicable diseases, we rely on medical devices that, yes, deliver tremendous value and advantages, not only in monitoring, but potentially down the road, preventive care, patient-generated data coming off that. We are very far from having the scale and the ability to have blockchain mediate interactions between medical devices and any other regulated technology medium for doing that. That said, it's an important hunt and something to be concerned and focused on. We also need a 5G world to enable the volume of devices that we'd be talking about in any any specific space, any limited geographic area. The amount of devices and applications beyond medical things is significantly large. So blockchain in and of itself, when you start to hear and read about how it's going to enable this patient-generated data and devices talking to one another, give pause. There are quite a few things that need to fall into place. That said, we think it important to get that chain of custody of a medical device and its physical, as a physical asset, but its actual condition, particularly if it's software enabled, particularly if it's connected, is interoperable with a medical record or with another device. And importantly, if that software enablement contains algorithms that control the functioning of the device. How did I get into this? Part of the way I got into this was I was chief risk officer for a large financial services firm, and cybersecurity was an acute concern for two reasons: protecting client data, now patient data in the healthcare setting, and ensuring that we were operationally resilient should cyber attacks occur against financial market infrastructure. I am acutely concerned that medical devices could be attacked. I am acutely concerned and understand that knowing and understanding those vulnerabilities and being able to patch them is addressed. That is not happening remotely on a machine-to-machine basis at scale for a long period of time across a wide range of devices, yet we continue to enable more and more devices with sensors and software. So let's start pragmatically in the world we're in today, step in and connect that ecosystem, and then step out over time as the enabling technologies allow us. But for now, at the Mayo Clinic, the Chief Information Security Officer has recently shared that he has over 25,000 connected devices in hospital. Actually, for a 400-bed hospital, there typically are about 25,000 devices overall, of which about 1 in 5 is connected. Almost 40 devices a bed, if you were to go into hospital on average. Many of them now connected and enabled, many soon to be. So it's a real problem. Of those 25,000 devices, the Mayo Clinic CISO said there were 6,000 unique makes, models, and versions underneath that for those that were software enabled. 6,000. 20 different operating systems underneath that. I'd argue if I had a verifiable record and understood from an audit standpoint underneath that what actually was on that device, whether it had been upgraded timely, whether a vulnerability was there, and rapidly traverse that supply chain to know and understand which devices were where, and either remove them from use or upgrade them, that we'd have a huge advantage. So that is what we're working on specifically at Spiritus and with the help of the Data Lab and Bill at Napier, as well as the sponsorship of the National Services Scotland. We're very optimistic and pleased to be here. Precision medicine, adverse events. If something does go wrong with a medical device or with a pharmaceutical, now you have the opportunity to much more quickly, again, identify who are the patients that are using those devices. And then clinical trials have been mentioned, as has public health more generally. An example from public health I'd give you is the CDC, the Center for Disease Control in the United States, just a couple of weeks ago announced that their experiment and pilot with regards to blockchain will be around disaster relief. Those first few hours and days when people are scrambling for the basics of life, yet potentially in an pre-epidemic situation should they communicate disease or have other issues around the quality of water, food, and the like. Likewise, as individuals, if they do have some specific medical need, pharmaceuticals that they need or otherwise, that whoever happens to be there at that moment with that individual is in a better position to enable and provision them with what they need. That's the CDC experiment, and it's a very interesting one. Use cases. This is a general purpose framework that I developed some time ago, really around finance, and I find it's useful when you're trying to think about blockchain use cases and what the ways to separate the kinds of opportunities that are there. So what I've represented is the concept of a transaction of some sort and a period over which it is, to use financial terms, cleared and settled. There's agreement that it's a good transaction and the parties that are involved can move on in one fashion or another around that exchange that has occurred between them. Across those 4 dimensions, you can read it as going from a very large volume of transactions to a relatively small volume. So think in the equity markets in terms of securities orders or securities trades in the billions on a daily basis and the volumes per second that implies. Across time, from orders actually in milliseconds getting to the exchange or to whatever venue, pool it might be traded at, to days or weeks, depending on the asset type. The volume of data that's involved, relatively speaking, or dollar value that's involved could be an alternative here, from relatively small to extremely large in finance. If I were to use dollars rather than data as the benchmark out there on the right, you could think again of an equity trade, which is actually quite small with high-frequency trading right now, to a derivatives instrument that's a synthetic derivatives instrument involving hundreds of millions of dollars on the balance sheet in your upper right corner. And then almost by definition, associated with those longer time frames, you get process complexity. How many parties involved? How complex are the processes? When I first came up with this rubric and started to plot what was going on in the world in finance, it was remarkable how logically different use cases by asset class or underlying business process fell into either one of the upper right-hand corner or the lower left, and then some more interesting use cases kind of in the middle. So in that lower left, as I've said for finance, you could look at what I would consider to be the utilities, the exchanges, or DTCC or SWIFT or otherwise payments. In that lower left-hand corner, really high transaction volumes, low latency, frankly low friction in the system, but some would argue potentially existential risk for the providers. And in the upper right-hand column, that is where you find the derivatives instruments. That is the big hunt that I think the big investment banks are on, is to cut the balance sheet exposures and capital requirements they have against derivatives and generate better returns around that. But let's go back to the healthcare example. Now we have down in the lower left claims. High volume processing, the big payers in the United States dealing with millions and millions of transactions associated with procedures that are provided, prescriptions and other things associated with the patient that may have an episode of care, even if it's routine, and the associated claims process. My approach as a US citizen and user of insurance, private insurance, is I usually sit around and wait for the claims notice to come through about 5 or 6 times till it's good. No one ever chases me, and usually it changes, and then I just wait, and I wait, and I wait, and then I feel like I've got a pretty good number, and then I'll write a check as I'm obliged. Claims processing is quite broken in the United States, and that's nothing to say for how it connects to actual clinical outcomes and results in preventive care. But it clearly is an area, and there is work in the United States around claims processing among the major players with regards to blockchain. And then precision medicine at the other extreme. Precision medicine, as understood, is that personalized care where whatever it might be, that treatment as represented by a surgery, it might be represented by a custom pharmaceutical that's delivered, or the use of a device or otherwise, is tailored to me, but then that information over time is longitudinally captured so that if I have a developmental disorder or a chronic disease that is in a state of degeneration, I can track and follow that. So long periods, highly complex data flows may represent an individual. Certainly want to take that learning and apply it more generally to populations. Those, I would say, would be examples of extremes. If you go back to my other chart here, you can lay out the other examples as illustrations and start to tease it. That's what I would encourage a management team to do in first looking at this, is to push on those extremes in terms of the business model. And what are we trying to accomplish here? Common to finance, common to any industry where safety, security, and compliance are concerned, as in healthcare. There are reasons why we have regulations. Common in those areas is the need to improve awareness and educate regulators. Challenge there is, as Angela has pointed out, we need to be careful about the language we're using and clear about it so that there's not a mistranslation across. Privacy, security, and data sharing, not taken for a given, certainly in healthcare, but central. Importantly, across jurisdictions, the definitions of privacy, security, and data sharing with regards to my data as a patient vary. So similar to finance, it's not enough to say that one regime is more strict. It's important to know that they're different and what ways they're different. As such, if you're in healthcare and you're contemplating a solution that goes cross borders, you need to concern yourself with those distinctions and ensure that you're in good shape with that. Getting regulators to know and understand is one thing. Having room in a sandbox sense, as the FCA here in the UK allows, for experimentation, to provide guidance on an informal or formal basis, and importantly, to get to standards. To that point, standards. In healthcare, there's a larger problem that is around standardization and interoperability, and very large challenges. Here's where I see a need for more discipline, just as there was in finance, more discipline in the use of blockchain and what blockchain can and can't do. Blockchain cannot solve the interoperability issues around patient records. Blockchain cannot solve issues that reside much more on the analytics side than they do around the validity of the record. And there is loose use of blockchain and conflation of blockchain as an answer to that. Governance and accountability, Angela's written some wonderful papers on that more generally in the blockchain community. It remains an issue, and these will be questions regulators will have. If in fact we have private, permissioned networks or consortia, there needs not only to be transparency at the appropriate levels for the parties, but the regulator as well is going to expect and have a framework by which to think about governance and accountability. I mentioned cross-jurisdictional issues. All of this goes up against the common problem in the developed world and in the developing world, that with affluence, lifestyle, and other habits that aren't suitable for long-term health, much less preventive care, that the real challenge and the real hunt is real-world evidence and clinical implications that we derive from real-world evidence. So when I look at innovation in healthcare and take blockchain out of the picture, in the end, the burden of proof on any introduction of technology is not just around that individual patient, but broader clinical implications and real-world evidence. So to the extent that blockchain can address whether or not a record can be considered valid is of interest, but it's not a given. And the bar is going to be extremely high, and there's a lot of argument in the scientific and medical communities just what real-world evidence means. So again, let's not take these for granted, particularly as you move into complex areas. Technology, privacy and security. Bill referred to it. We're pleased to have him as a partner. I certainly don't take from the background I have in cybersecurity and concerns about critical infrastructure. I don't take it for a given just because I've got cryptographic proofs that I have a secure infrastructure and a secure network. That needs to be hardened and tested, and unfortunately, part of that testing would be to expose to the wild and find out just what those vulnerabilities are. But finance has a good track record of running simulations around its current infrastructure, and I think there's a model there for anyone that is moving into a private permission network that they hope to build to run simulations and attacks that may look similar to the kinds of things we've seen that have led to forks in the Ethereum community, but may be specific and germane to that particular ecosystem and party of players. Another issue around technology is its actual immaturity and the fragmentation that we can experience. As you research and look into it, you can see that at least at the protocol layer and infrastructure layer, there is starting to be a lot that is laid down and starting to firm up and choices that you can make. The large technology providers are certainly trying to support blockchain as a service, if you will. But just as I suggested, the use case is central. What problem am I trying to solve? Is blockchain the right mechanism? Really, blockchain is about, yes, auditable records, but importantly, the network that's agreeing and for a business reason or other reason wants that transparency. And the formation of the consortia that are specific to a sector and the networks is as much craftsmanship and building on trust that exists and understanding where mistrust does exist or a need for transparency is. And that's hard work, and that's not coding, but it ultimately will be coded. R3's done a tremendous amount of work on the concepts, and the reference architecture for Hyperledger as well reflects different mechanisms for validation, different roles for the various parties in the network. And I think healthcare is going to have the same emergent concepts about what networks matter, but importantly, understand what and if there might be interoperability with other healthcare-related blockchain networks, the financial system network. You don't have a claims process if you're not connecting to some payment mechanism, right? So we're going to have a world in which there will be emergent subledgers and interoperability across chains within a sector, but how a sector connects to another sector. I'll not stand here and forecast what that's going to look like. I'll know that ultimately there will be gateways that allow you to move from one sector to another, from one function to another, geography as well, have the integrity of the network understood and accountability in that network understood. This point about confluence with machine learning, AI, in the case of healthcare, high-performance computing, a lot of the calculations that go on, whether it's in genomic medicine, looking at patient-generated health data or otherwise, AR and VR and IoT, I've referred to them as well. Listen carefully, whether it's in the healthcare area or other sectors. Listen carefully to what's being presented. What was presented a use of blockchain, or was it actually robust big data and data analytics? That is very often conflated and dangerously conflated, so no one understands, because as Angela has referred and as David has as well, let's separate out what we're asking of blockchain, what blockchain actually enables, and that other stuff. Is it a stage setter and a checker? What role is it performing? And I mentioned patient data sharing and identity. Coming from financial services, having the data protection regime here in the UK to concern ourselves with, as well as what US regulators were expecting, I have a lot of sensitivity to that, and a broader understanding within the blockchain community that actually a lot of folks are working on what they call self-sovereign identity, the idea that I'm in control of my identity. There are verifiable claims that I present, whether the illustration of this morning of showing up at a bar and just being able to verify my age, not necessarily where I was born or what eye color I have that identity. In healthcare, there's this preoccupation with patient data and patients being in control. Well, the first presumption is that patients care and want to be in control, and if they are in control, they understand that. That's an issue separate from blockchain. It is a huge, nettlesome issue for healthcare, is do I need motivated, engaged patients? Yes. Motivated and working effectively with their practitioners, managing their lives? Absolutely. Does that mean they need to touch and control their patient record? Ooh, do I even want to do that? Right? What does that mean? That is a problem that is a broader problem that blockchain does not solve. It may enable elements of data sharing. It may enable me to participate in a clinical trial because I have reason to believe that there's a family history and there may be genetic associations with a certain disease process, and I want to join a remote clinical trial. That might be a valid use, but to conflate and assume that the patient data sharing and the identity that comes from potentially blockchain-enabled systems exists exclusively around me as a patient is wrong. And I have, when I'm in front of healthcare audiences, had to step through this exercise, which in fact is a loop back to the beginning of the day and how the Scottish government is thinking about this being more robust across our lives. In a healthcare sense, I, yes, am a patient from an embryonic state, if you think of genomics and what it might offer down the road, through healthy states, disease states, end of life, and the like. And I expect that I will have protection around fraud. My privacy, the suitability, the sharing, the safety and effectiveness will all be taken care of. But I have similar concerns in my financial affairs, as a depositor, as a borrower, as a pensioner, as an investor, and a giver. And my economic life, and also in my civic life. This is the self-sovereign identity richly understood. So again, as I look in finance or I look in healthcare and I see people just trying to solve around that and not understanding the larger context in which I'm going to introduce to my 82-year-old mother in Cleveland, the concept of her owning her identity, being self-sovereign, and selectively sharing verifiable claims against her identity. I mean, that's a funny conversation. I have an easier time talking about the Cleveland Browns than I do talking with her about self-sovereign identity. But I think important, at least for those in healthcare, is continually for them to know and hear and understand this message. You're not solving exclusively for control of data by an individual. They are also a financial actor, an economic actor, and a citizen. And so rightly so, I think I feel encouraged that Scotland is thinking holistically about that, but it goes to the identity elements of this as well. I'm grateful for the time. We are pleased to be here in Scotland. It's hard to describe the community and the embrace. I trust that over time we'll see that this event and this conference becomes larger, that we're able to bring in elements around big data and other areas that MBN works to see the interaction and tease that out and work further. So on behalf of my teammates at Spiritus, I thank you very much and appreciate your time.